Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Talk to us about the use of ibuprofen and acetaminophen, which is otherwise known as Tylenol. And they talk a lot about the fact that they have been used for very similar situations for headache, muscle aches, joint pain, cold, flu, and dental pain, cramps. And what is the difference? When can you use one? When can't you use the other? And the real issue with the acetaminophen and the Tylenol is that it, of course, if you take too much of it, you can get liver disease, particularly in people who drink a lot of alcohol. And with the ibuprofen, you can cause too much of it can cause liver uh, liver disease. So ibuprofen can cause the kidney disease. Tylenol can cause liver disease, but they're all pretty much beneficial as long as you are very careful about not taking ibuprofen more than 4 times a day and not taking more than 4 grams of Tylenol. But that's kind of an all-purpose medication that people tend to use for many different reasons, but have to keep in mind that when you take too much ibuprofen, that can lead to kidney disease, and too much Tylenol can lead to liver disease. But they're anti-inflammatory agents that are very helpful for many issues. I don't know how many of you use the so-called NSAIDs or ibuprofen or the Tylenol for any of your ailments. Any of you use either of those drugs?
I had an extraction that was very, very painful, very, very painful. And they gave me a whole prescription of ibuprofen. I think the 800, they called it.
Yeah.
Milligram. But I was blessed. I only had to take one of them.
Oh,
After
okay.
that, the pain went away. Yeah.
Good. Yeah, it's very good for aches and pains and fever, those kinds of things. Anybody else have to take either of those? Because as long as you don't take them in excess, they're very helpful drugs. But when you start taking them chronically for a long term, that's when problems arise.
John, okay,
Yes, my husband takes Tylenol. He also takes a leave sometime, don't you? Is a leave part of that same group?
Yeah, it's an anti-inflammatory. You like that. Yeah, it's like ibuprofen. Yeah. It is less associated with the side effects of the ibuprofen and the Tylenol.
Mhm.
I heard that a leave raises your blood pressure, though. Is that true?
I don't know. I never heard that was a side effect of a leave, so I don't know about a leave causing. I'd never heard that, but I don't know.
Like, young women take Midol for menstrual cramps, and some Midol products contain NSAIDs.
Yeah, and they're the ones that if you when you start taking either of these products more than 3 times a day, then it can cause other problems. But if you only take it once or twice a day, then you usually don't have many side effects that are problematic. There's a 92-year-old lady who is setting all kinds of track records. Reminds me of the Tatums when they were doing their swimming. And they tested this lady. She's 92 years old, and she started exercising in the 60s, and she's 92 now. And they're finding that most of her lab results suggest that she has the strength of somebody who's half her age. Uh, and the model of the story that they were projecting is that it's probably never too late to start exercising. Uh, she started, I think, in her 60s, but it's never too late to start. And the benefits of exercising and uh, continue to occur, even though you may start uh, later than most other people. It's interesting to notice that some very young people are not very interested in exercising, although the many benefits of exercise are evident.
You know, we as kids learned to exercise in school because we had gym and we did different things in school. But now that they've cut that out of school, and of course, all the new fangled things that kids have to deal with to just sit around and play on, they don't get that exercise, or they don't even think about it. I don't think sometimes they don't even think about exercise, which I think is a very bad thing for them.
Yeah, I was interested because I noticed that some of the private schools still have exercise, whereas the public schools don't. Uh, Dr. Perez?
And I think the things that we do together, like exercise, I know I'm looking forward to the 10 minutes, which is a lot out of 90 minutes about that uh, church service, where I mean, the leader, the trainer gets the heart rate up in church. And I've heard some of our more senior saints doing it for the first time. And I know that it's how we socialize also with our exercise as our children.
Guess her computer failed too. Betty?
Yes, my husband told me to ask the question, if you exercise in your sleep, in your dreams and stuff, does that have any bearing on your health at all?
I have no idea. I never heard that question before because I think exercise in your sleep is probably not exercise. But I don't really know the answer to that question because I've not read anything about people exercising in their sleep. I only know about the live exercises.
He
So
says he feels tired when he wakes up, so he wondered whether.
well, I can't. I have no answer to that. That's a good question that I can't answer.
Okay.
And some folks have restless leg syndrome, and that your legs are moving while you're sleeping. That could be.
Yeah.
Yeah.
Well, because I have drop foot, my leg moves too when I'm sleeping, or whenever I'm laying down or sitting for a long time, it moves
Good
involuntarily.
morning,
So,
good
yeah.
morning, Dr. Callender.
You're on mute.
Good morning.
Okay. Are you ready for your presentation, Dr. Callender?
Yeah, sorry for the delay.
Okay. Dr. Ealena Callender is a graduate of Maryland Medical School. And then I went to Howard University uh, for 3 years of her OBGYN residency and then finished actually in Dayton, Ohio at Wright State University. And for the last, what is it, 20 years, she's now been a practicing obstetrician and gynecologist. And so today she's going to share some of her expertise as actually she's a hospitalist because, we've had a number of discussions about hospitalists as well, uh, but she's going to talk today about the problems that women face as they get over 50 and have to deal with the issues of uh, of when to get examinations, when not to get examinations, and the rest of how to age gracefully as you get over 50. Okay, it's up to you, Ealena. Welcome.
Okay, thank you. Let's see. Okay, can everyone see my screen?
Yes.
Okay. All right, so we're going to talk about women's health after age 50, 50 being the average age of menopause. So we're going to talk about some guidelines and recommendations. So many women are not sure if they still need to see a gynecologist after they go through menopause. But nowadays, with the life expectancy in the United States of America, women can expect to spend about a third of their lives after menopause. So that's a long time to not see a doctor. So the answer is yes, absolutely yes. You need to continue seeing a gynecologist after menopause, after you're finished having babies, and in your later years in life. So, the annual GYN exam, just a routine exam, for women after menopause should include a pap smear until the age of 65. I think we're all familiar with the term pap smear. It's a test that's done to help prevent cervical cancer, and the test determines whether there are any abnormal cells in a woman's cervix at an early stage so that cervical cancer doesn't have to happen. So it's a very deadly cancer, but we have lots of ways to prevent it. So it's one of those cancers that shouldn't really ever have to happen. So your exam should include a pap smear, a pelvic exam, and a breast exam. You should have screening for osteoporosis, and you should talk to your doctor about immunizations. And the required or recommended immunizations, of course, will change at different stages of your life. So some common issues that women face after menopause include pelvic organ prolapse. So that's weakening in the muscles that keep the GYN organs in place. And that can cause pelvic pain, pressure, or problems with urination. Also, women at this time of life often face urinary problems, and that can be difficulty holding in urine or feeling like you always have to go. Other issues include vulvar or vaginal irritation, and so that's itching or burning or just a discomfort inside the vagina or on the external organs, and also difficulties with intercourse, including pain with intercourse. So this is just a diagram of the female organs. Of course, we have the uterus, and the inside of the uterus is called the endometrium. The tubes on these sides, these are the fallopian tubes, and they are near the ovaries. And this here, the lower part of the uterus is the cervix, and this tube is the vagina. So one thing that we need to be aware of is the presence of GYN cancers, and most of these are much more prevalent as we age. So there's cervical cancer, which I mentioned a little bit, ovarian cancer, uterine or endometrial cancer, vulvar cancer, and vaginal cancer. So cervical cancer, as I mentioned, is one of the most preventable and treatable types of cancer. It's and unfortunately it's very common because we know now that it's caused by sexually transmitted infection of human papilloma virus. But since we know what causes it, we have immunizations that are available to help prevent the changes that can be caused by the virus. And we have the pap smear, which can detect changes very early. And we also have treatments available for those early stages and before it gets to the point where it becomes deadly. So more than 4,000 women die from cervical cancer every year. And 20% of those cases occur in women over the age of 65. So while it's something that most women will be exposed to through the course of their lives, it's a very slow-moving cancer, and the severe cases will show up in women over age 65. Hispanic women are 60% more likely to be diagnosed with and 30% more likely to die from cervical cancer than white women. Black women are 80% more likely to die from cervical cancer than white women. And symptoms of cervical cancer, talking about symptoms, but the best approach, of course, is prevention. So getting regular pap smears, seeing your doctor regularly is the best way to prevent getting cervical cancer. But when they are symptoms, they can be something like vaginal discharge, a change in vaginal bleeding, pelvic or abdominal pain, vaginal bleeding after intercourse, which is called postcoital vaginal bleeding. In the advanced stages, there can be a foul-smelling vaginal discharge and pelvic or abdominal pain. The guidelines say that until the age of 65, women should get pap smears. It starts at age 21, and then every 3 to 5 years, they can get cytology alone, which means just getting a swab that shows us the cells. And every 5 years, it can be testing alone, that is just to test for the presence of the virus HPV. Co-testing means doing both, getting the cells and testing for HPV, and that would be every 5 years. After the age of 65, no screening is necessary if there have been negative screening results for several years prior to the age of 65. If a woman has had a hysterectomy, which means removal of the uterus and cervix, then they do not require any further screening as long as they don't have a history of any serious changes in their cervix prior to the hysterectomy. Or if the hysterectomy was done because of a cervical problem, then screening would continue. Ovarian cancer. It's the number one cause of deaths from gynecological cancer in the United States. About 20,000 women will be diagnosed this year, and about 13,000 women will die from ovarian cancer. Ovarian cancer is very deadly, and unfortunately, we don't have a screening test for it. So, but there may be symptoms, and they're vague symptoms, but that's a reason why it's very important to see a gynecologist so that they may do the pertinent exam and maybe ultrasounds or imaging to pick up on those very vague symptoms. Risk factors, of course, age over 55, any family history of breast cancer, ovarian cancer, colon cancer, or endometrial cancer, a personal history of breast cancer. And there are certain genetic mutations and syndromes. You may have heard of the BRCA mutation, and there's also the Lynch syndrome. These are syndromes that can run in families because they're based on certain genes that happen that increase our risk for breast or ovarian cancer. There's also an increased risk for women who have never had children, a history of infertility, or a history of endometriosis. So these are facts that everyone should know about ovarian cancer. As we know, most women are aware of the pap smear, but we need to understand that that is a test to help prevent cervical cancer. It doesn't help us detect ovarian cancer. Because of the vague symptoms, ovarian cancer is often found at a very late stage when it is very deadly. Diagnosing ovarian cancer before it spreads makes it much more treatable. So again, that's an argument again for going to see your gynecologist regularly. Symptom awareness might lead to quicker diagnosis. And again, the common symptoms can include persistent bloating, abdominal bloating, difficulty eating, feeling very full quickly, like you eat a meal and it's a very small portion and you can't eat anymore because you're full, pelvic or abdominal pain, and urinary symptoms. Again, unfortunately, there's no reliable screening for or a diagnostic test for ovarian cancer. So it's important to know signs and symptoms. And of course, the signs and symptoms can be attributed to other things as well. But it's definitely these are definitely things that you should be aware of and talk to your doctor if you're noticing any kind of pattern with these kinds of symptoms. So again, it's most often asymptomatic, meaning there are no symptoms that are specific to ovarian cancer. Again, the symptoms can be vague and associated with other health issues. So it's important to see your OBGYN and make sure you get a regular pelvic exam. So uterine or endometrial cancer, this is the uterus, and the inner lining of the uterus is called the endometrium. So it's cancer inside that uterus, and that's happening in cells that are part of the endometrium. So this is the most common type of cancer that affects the female reproductive organs. Most cases of endometrial cancer are diagnosed in women who are past menopause and in their mid-60s. It is the fourth most commonly occurring cancer in women. The age-adjusted mortality is 84% higher among Black women. That means Black women are much more likely to die from endometrial cancer than white women. Every year, there are more than 65,000 new cases, and an estimated 12,550 women will die from endometrial cancer this year. Risk factors, risk increases with age, obesity, genetic syndromes, like I mentioned before, a history of polycystic ovarian syndrome, a history of breast cancer that was treated with tamoxifen, starting your period very young or going through menopause very late, and never having been pregnant. So those last two things are associated with essentially having more periods during your lifetime. Symptoms, the most common symptom is postmenopausal bleeding. So after menopause, after you've had a year of no bleeding and you're considered to be in menopause, anytime you have vaginal bleeding, even if it's just a speck that you see on your underwear, it's cause for calling your gynecologist and getting evaluated. So other symptoms of advanced endometrial cancer include abdominal or pelvic pain, bloating, like feeling like your belly is really, really big, feeling full quickly after eating, and changes in the bowel or bladder habits. Vulvar cancer. So this is cancer on like the labia or the outside parts of the GYN reproductive organs. Symptoms that are most commonly seen include itching or burning or pain on the vulva, a lump, sore, or swelling or wart-like growth, thickened or raised patches of skin. They can be changed in color and they can be red, white, or brown. You might have a mole that changes in color or shape, a lesion or sore on the vulva, or hard and swollen lymph nodes in the groin area. If you do have any of these symptoms, it's important to see your gynecologist. There are no screening tests except for having a routine exam and getting a routine pelvic exam. You're having someone look at the area, and it's important yourself to be aware of any changes when you just look at yourself. The average age at diagnosis is 68. Prevention, the HPV vaccine can help prevent this type of cancer because sometimes it is caused by the human papillomavirus, which is also what causes cervical cancer. But there's a different type of it that can cause changes to the skin on the vulva. Again, risk factors, this type of cancer, the prevalence increases with age. Risk factors include smoking, having a suppressed immune system, or having a skin condition involving the vulva. One common condition that we see is called lichen sclerosis. Vaginal cancer, of course, this is cancer that can occur inside the vagina. So it's not inside the uterus or the tubes, but in the external part in the vagina. It's quite rare. There are about 5,000 new cases every year, and the average age at the time of diagnosis is 67. And again, we have HPV here, which causes most of these types of cancers. So that's our review of GYN care in women over age 50 and cancers. But I also, I'll take this down, stop sharing. Okay. So it's definitely important to go to see your gynecologist even after you're done bearing children, after you've stopped having your periods, even after if you've had a hysterectomy, it's still important to go. Like I mentioned, a lot of the symptoms of these cancers are very vague. Even with vulvar cancer, if no one is looking down there, if you don't have any itching or burning, and you're not looking, you may not see something. So a regular exam by a gynecologist is important to catch those things that we may not be paying attention to or we may not notice. Some of the other issues that women face after menopause include osteoporosis. That's weakening of the bones, and we stop making our bones stronger around age 30, and so we start losing bone mass after that, and it becomes more rapid even after menopause. So it's important to make sure we focus on strengthening our bones, and that's something you can talk to your primary care doctor about, but also your OBGYN as well. And again, I'll mention what to expect in an exam. So during the exam, you should talk to your doctor about your history, any changes in your health history or medications, and you should have a complete physical exam. Going to the gynecologist isn't just you're not only talking about your reproductive organs, but you should have a complete head-to-toe physical exam where you take all of your clothes off, and it includes a breast exam and a pelvic exam. And the pelvic exam includes just looking at the external areas, but also looking inside and doing a manual exam to palpate for any masses or any pain or discomfort that you may have. So again, the answer, do women need to continue going to the gynecologist after they've finished having their periods? The answer is yes.
You open for questions?
I am open for questions. Absolutely.
First question is, how often should a woman see her gynecologist after the age of 50?
I say every year. I know that Medicare pays for an exam every 2 years, but it's definitely important to go every year. And if you're going every 2 years, it's important to notify them or talk to them or see them if you have any problems that arise.
Um, you mentioned in your talk about polycystic ovarian syndrome.
Yes.
What what is that?
So that is a syndrome that can it's a actually it's called polycystic ovarian syndrome because of the appearance of the ovaries when this syndrome is present, but it's really a metabolic condition. Most commonly, as for the GYN part of it, women have irregular periods. They may have periods that are longer or shorter, and they may come every too close or too far apart. So that's the most common symptom that people come to the doctor for. But we do notice a change in the or a difference in the period in the appearance of the ovaries, but also it increases a woman's risk of other complications like diabetes, obesity, hypertension, and later in life, it can cause increased risk of certain types of cancer.
Darryl?
Yeah, thank you, Dr. Callender, for a great presentation. Uh, you mentioned that Black women were most likely to die from cervical cancer and uterine endometrial cancer. What factors cause that?
It's mostly there's different reasons for some reason, especially for uterine cancer. Um, Black women tend to have a certain type that is more deadly, but also Black women tend to be diagnosed at later stages.
When you say they have later, you mean we go to the doctor, we don't go to the doctor after we're 50? And
Either
so
they don't go to the doctor or they don't get evaluated for the the presenting symptoms fast enough, or they are not evaluated properly. There, like I mentioned, there are certain types of cancer that are more aggressive, and if they go to the doctor with a complaint, and they may be evaluated in a, I guess, less aggressive way, and so they may not be diagnosed sooner than later.
Is obesity also a factor?
Obesity is a risk factor, definitely for it increases the risk of endometrial cancer for sure.
Buchanan,
Yes, thank you, Dr. Callender.
Yes.
I had several questions while you were presenting. The first one shocked me, the number of deaths from cancer uh, with female structures. And the other question sort of is like, uh, why are there different cancers in the different structures in the female sexual organs? Why would it be in one part and not in another part? Is that a valid question? I don't know.
Um, they are all different organs essentially. So like the ovaries have a very different function and they work differently than like the fallopian tubes. And the uterus, the body of the uterus has a different function than the lining of the uterus. And those are also very different from the cervix. So we kind of think of them as all like kind of one block, but every piece is very different and has a different job to do and has different complications or diseases that can be associated with them. So
But why would cancer be in one part and not another? That's a big question I have.
I mean, I guess cancer always starts somewhere and then it can spread. So like with ovarian cancer, the risk increases essentially the more periods a woman has in her lifetime. So let's say, I mean, women physiologically, our bodies are meant to reproduce. So the less we reproduce, the more periods we have, the more times our ovaries are going through this cycle trying to produce eggs, trying to get pregnant. They keep going and going and going and going and going with no break. So if you think of like a machine that keeps going and going and going and going and going, the more it's going, the more likely something is going to go awry. So if you think of pregnancy as sort of like a time of rest for the ovaries, a woman who goes throughout her life and has, baby after baby after baby, she's having much fewer periods. Her ovaries are kind of resting more. So her chance of having a complication or having some sort of misfire or something in her ovaries is lower. So it's all about really the function of the organ, and cancer has to start somewhere. It starts on a cellular level, and the cells, on a very basic level, in each of these organs are very different, and they have very different functions.
And thank you. You answered my next question already about the women who have never been pregnant have a higher risk of cancer, right?
Right. And for ovarian cancer, yes.
Okay. Thank
Yeah,
you very much.
of course.
Uh, Joyce, next.
Thank you, Dr. Callender, for your very informative presentation. John kind of tapped in on the question that that I am going to ask, and it has to deal with women who have never had a baby, and I am one who have never had a baby. My question is, why are the cancer risks greater for women who have never had a baby?
So that's because of the way the organs work. And if you think physiologically, like the way our bodies are designed, um, our body, every month when we have a period, it's because our body is expecting pregnancy. And then we don't get pregnant and we have a period. So every single month, that's what our bodies are trying to do. So when we so our bodies when we're not getting pregnant, our bodies have to continue doing that over and over and over again, trying to, going through a cycle, going through the same cycle. um, and there can be, the more times our ovaries go through that cycle, the more chance there is for some sort of complication or some sort of um, problem in the cells that can, where they can reproduce improperly, or they grow improperly or something like that. So the fewer, it's really just about the more the ovaries are going through that cycle, and there's just more of a chance for something to go wrong.
Okay. Now, I had a very challenging menstrual cycle. And would that have anything to do with not being able to become pregnant and the cancer risk?
Um, Challenging meaning,
Heavy flow, clots, a
so
lot of that.
okay, so it's hard to say. Women who don't have a regular period,
Mhm.
like we were talking about the polycystic ovarian syndrome, women who have that syndrome are at greater risk of having like endometrial cancer.
Mhm.
Um, Heavy flow specifically is not tied to a specific cancer, although someone with heavy flow should be evaluated to see if they have any problems in the structure of the uterus, including like any masses in the uterus or any abnormality in the lining of the uterus.
Okay.
Mhm.
Thank you.
Of course.
Uh, EOS one. You're next for questions. EOS 1, I don't know who that is.
We can't hear you.
You're muted.
Oh. Hello, I'm Dolores.
Hi.
Hi. I didn't hear you mention anything about fibroids because I hear a lot. I had fibroids removed, and I hear a lot of other friends and women talking about the fibroids. Is there any updated information on that?
So yeah, fibroids is very common. Probably about 1 in 3 women have them. Fibroids is a type of mass that can happen inside the uterus. So it's most often not cancer, but it can cause problems with bleeding, heavy bleeding, pain with your periods. Sometimes because they're so big, it can just be painful all the time. It can affect your bowels. It can affect your bladder if they're very big or you have a lot of them. So they can definitely cause problems, and they're very common. So yeah, that's definitely something that a lot of women deal with and a lot of Black women deal with. There is a less common cancer that can grow out of a fibroid, and that type of cancer is more common in Black women. So again, if you do have complications with your periods, very heavy bleeding, a lot of pelvic pain, these are all reasons for you to see your gynecologist to be evaluated to see if there is a reason for it that can be treated.
Thank you.
Mm-hmm.
Thank you, Dolores, for your question. Dr. Perez, next.
Thank you for your wonderful presentation. And I have 2 questions. One, what is your recommendation for women over the age of 70? Annual gynecologic examinations? That's one.
Okay.
And 2, I was blown away by the disparity in the number of cases of cancer in Black women versus any other ethnic or racial group. And it's just, it seems to me that the biggest disparities across the board seem to be with Black women. Could you speak to that and how we're addressing that? Is this new knowledge?
So I think women should go to a gynecologist as long as they are women. So that means forever. Maybe not as often, like after you're 80, but definitely you should still go because, like I mentioned, there are still the risk of problems just goes up as we age, and unfortunately, doctors who are not OBGYNs are not. They just really aren't very interested in what's going on down there, right? Like they don't. If you go to your primary care doctor, they may not ask you any questions about your gynecologic organs. They definitely don't want to look at it or do a full exam. And so, of course, a woman who's in her 70s is at a higher risk of vulvar cancer than a woman in her 20s or 30s, but it's less likely to have anybody examine her. A lot of time I've seen women who have itching on their labia or in their vagina, and they tell their primary care doctor, who orders them a prescription for a yeast infection over and over and over and over again. And it turns out she has vulvar cancer by the time she comes to see me. So, yeah, I think it's definitely important to continue seeing a gynecologist. And if you just see a primary care doctor, it's important to talk about everything, not just your heart and lungs, but also what's happening with your reproductive organs. And if it seems that they don't feel comfortable talking about it or doing an exam, it's important to get a referral or to just decide to go to see a gynecologist instead. As for the disparities, I think, on the most basic level, we have to admit that it comes down to systemic racism and the way we are managed. And, there are a lot of communities in this country who are afraid of going to the doctor because they don't expect to be treated well or for their concerns to be really addressed. So with people who don't want to go to the doctor, then you have people who are diagnosed at very late stages, or people who don't have money to go to the doctor. They don't go until they have symptoms. And usually when symptoms occur from these types of cancers, the disease is very advanced. And then you also have some physicians who actually don't take our concerns seriously. And so we may get, put off until the disease becomes more serious. So it's complicated. It's not that it's just like on a cellular level that the cancers are different necessarily, but it's also in the way we are treated in society in general.
Okay, Darryl, you're next.
Okay, you were talking about one of the symptoms for ovarian cancer being a small appetite. Is that usually accompanied with dramatic weight loss?
No.
It can be. Again, that would be, over time, if you're eating less, you're going to lose weight. And so that's one of the things that we ask people, if you're losing weight, is it something that is it intended, like unintended weight loss? We ask about that. So that would be definitely something that would cause concern. And it's not just like, 1 day or 2 days, it's over a long period of time.
Okay, and I had another question about ovarian cancer. You were saying that childless women have the greatest risk of ovarian cancer. And of course, any children at all would be preventative. Is there an optimum number of children that a woman should have to prevent ovarian cancer? And when I say optimum, the number beyond which there's no further benefit.
I don't know the answer to that. No, I don't know. If women use birth control, hormonal contraception during their lifetime, so they are not ovulating every month, that also can be helpful. But we're born with millions of eggs. Now we can't have no one woman can have millions of children, but we are born with the potential to be pregnant basically our whole lives. So no, I don't know what the number is. There might have been some studies on that, but I don't know.
Thank you.
Of course.
Joyce, you had your hand up.
Janice?
I thought I saw your hand, but maybe.
I did have my hand up, but my question had been answered.
Oh, okay.
Okay.
Well,
But again, Dr. Callender, thank you for your presentation. And it does relate to my family. I have a sister, or had a sister, who had ovarian cancer. And I've been told over the years, and also by you, it's difficult to diagnose. Mm-hmm. She went for a period of time of having, I guess, some female issues, going to see a doctor on a regular basis. And unlike the comment that Darryl made about losing weight, she gained weight. And it was all in her stomach. Mm-hmm. And her doctor just insisted, exercise, you're eating too much.
Stop doing this, stop doing that. And she was trying. She said, I just can't do it anymore. I'm tired. One day she went to the doctor. I think you have cancer. And that was the start of everything. And the bloatedness and the weight gain in the middle was the ascites, whatever. And she was so bloated until she had started wearing maternity clothes. Um, is it number one? I have two other sisters. Heredity, does that come into it? The other question is they did test her for the BRCA gene, which she did not have. And so then they told us you don't have to be as concerned. But in our weekly talks with Dr. Callender, he has always insisted the past several years, doesn't matter if you're over 65, go see your GYN. When I was 65, yes, I did stop. And recent years, I have been going for testing, pap smears, that sort of thing. But it does make my sisters and I wonder, is it heredity? Does the fact that she took BRCA, didn't have it, we're good? It was just something that we should be concerned about.
I'm sorry about your sister. Yes, it's something that you should be concerned about. There are, as you can imagine, most of the studies and most of the genes that we have found are, most of the scientific work is done on white European descendants, right? So there are definitely genes that we don't know about, that we haven't studied, that we haven't identified. Knowing and BRCA is really important because we know it, we identified it, and we once we see it, we recommend certain that you take certain steps to prevent your risk. But there are other genetic syndromes that we don't know about. And also, most cancers are not related to any kind of genetic syndrome. So I think, like I said, with ovarian cancer, it's one of the toughest things that we face as gynecologists because we don't have any screening, we don't have any definitive test, and it's deadly. So I would say that vigilance is the most important thing. If you, like your sister, keep going back to the doctor, you're not satisfied with the answers that you're getting. Go see someone else or take another route somehow. But that unfortunately is a very common story for women who have ovarian cancer. Some studies have found that it takes up to 5 years before a woman is diagnosed. And I look back and see that she was complaining of these things for 5 years, but no one thought about it because, as you remember, like in the presentation, that the symptoms are vague.
Yeah.
They can be associated with lots of other things, and bloating can be a problem with your GI system. It can be, a lot of women get fatter in the middle after menopause. So a lot there are symptoms that can be something minor, but also that can be ovarian cancer. So I think just to be vigilant and to make sure you're doing the basic thing of just seeing your doctor regularly, and advocating for yourself if you feel like you're not getting taken seriously or you're not just really getting the care that you think you need.
Good to know, and that advice I will follow and pass on to my other sisters. But when we think of the big picture with her, it was over a year. Back and forth, exercise, do this, do that. After diagnosis, it was possibly 7 months, I guess, before she passed. And you become bitter, actually. But then you learn to advocate for yourself. And I do that, with anything that I see out of the ordinary, I try to follow up on. And I pass that on to my sisters, especially one in particular who refuses to see a doctor about anything. But Anyway, I do appreciate your presentation.
Thank you. Yeah, I'm sorry.
Betty Blaylock, you have another question?
Yes, thank you, Dr. Callender, for the presentation. I have just been sitting here thinking about my own life and what how it played out. I was young when I started. I guess we all were young when we started our menstrual cycle. I had children young, and I ended up with menopause starting at age 40. So um, but back in those days, because I'm almost 82 now, so back in those days, my primary doctor would do my exams. I mean, after I had kids and stuff, I really didn't go to a um, specialist, but my primary doctor would do my pelvic exams along with his other examination.
Mhm.
But as we have stated several times on here, our primary doctors don't hardly touch us anymore. So I'm almost anxious to go see a gynecologist just to get an exam because listening to you, if you all still do a complete exam of the person, I'm almost ready to go just to get an exam. But I'm just wondering, you said that normal menopause starts at around 50. So mine started around 40. So is that any reason for me to be concerned? I haven't really had any problems with my um, organs. So do you?
Yeah, so the average age in this country is 52. So 40 would be considered early. And so the time the so you have more years of your life after menopause, right? And so after menopause, we deal with a lot of changes, and most I mean, after that time, our risk for other diseases increases. So for you, those risks increase earlier. One of them being osteoporosis. So once you're after menopause, our bones weaken over time, and then more dramatically after menopause. So that would be a concern. It is less osteoporosis itself is less common in Black women, but it is still something that can happen. And also just you have increased risk of heart disease and that kind of thing after menopause. Women do. So those would be concerns. I don't know if you were evaluated at the time, like if anyone was like trying to figure out why you had menopause early, or if it was just, sometimes it just happens. But that if there's a reason for it, that, that could be tied to some other complications. But sometimes it just happens that way. I'm definitely a proponent of a good physical exam. I think that in my patients, I have seen things, just on a routine exam, things they didn't complain about, things they, had no concerns about, but you just look and you find something. If you don't look, you won't find it. If you think about it, most of the diseases that kill us, they don't tell us they're going to kill us, right? Like we don't know they're happening, but they're happening in the background. Like hypertension doesn't hurt, but it will kill you. Many people are walking around with diabetes and they don't know it because they don't feel it. When by the time you feel it, it's very advanced. So that's why it's important to just go on a regular basis and find a doctor who gives you an exam that you're comfortable with.
Thank you.
Darryl, you had a question.
Yeah, about the discrepancy between some people start menopause at 40, but the average is 50. And of course, you could have some people that, if the average is 50, some people could start menopause after 50.
Right.
And my understanding, and of course, I know you'll correct me if I'm wrong, and I usually am, but my understanding is that women at birth, you're born between 1 to 2 million egg cells, egg stems, and of course you don't grow any more egg stems after you're born, and you're going to be shedding egg stems through the rest of your life, and you shed more through the cycle through menstrual cycles. Um, so someone is more likely if they start menopause earlier, they're probably on the shorter end of the spectrum. They were born with fewer egg stems. They were born closer to the 1 million. Somebody that's blessed with more towards the 2 million side of the spectrum, they're going to have a later start to menopause. Of course, menopause can be delayed by the number of pregnancies that you have because you're not having menstrual cycles. But I've read that the most that you're going to extend menopause by having children is just by a couple of years at the most.
Yeah, I'm not sure about that. I'm not sure if the difference in the eggs that you start with dictates when you have menopause. I know that there are like geographical differences and also socioeconomic differences, and when little girls start having their periods. And we've seen just in our lifetimes that has changed. So I don't know. I don't know. I don't know how much that is impacted by the number, or I don't know how much that's related to the number of eggs that you're born with. But that's an interesting idea. I do want to say one thing that I noticed is that it seems to me that there's a misconception among Black women about menopause. In that when we say menopause, it means that you no longer have periods. So we diagnose it after 1 year of no periods. Like I've heard people talk about women who just all of a sudden started having their period again, or they kept having their period until they were 60 or something like that. That is not normal. So any bleeding after menopause is cause for concern. If you start having a period after you stopped, you need to go see your doctor. So that's that.
Joyce, you had a question?
Yes, Dr. Callender, I have a niece who has Down syndrome, and she is 47 years old. She is now in menopause. Is there something that we need to be concerned about with her going through menopause at this early age? Um, um, because there's something that we don't know that much about. Her doctor is saying that she's in really good condition and everything is okay. But I just want to see if there is something else that we need to be concerned about, her health in that area.
I would say it's the same as, I mean, you have the same concerns as someone who went through menopause later, just earlier. So I'd be concerned about her bone health, her heart health, weight gain, because, overweight and obesity can lead to other complications. So if the doctor doesn't think it's tied to anything in particular, then I just would make sure that you watch out for those big areas.
Yeah. They have started her on the D3 and increased her calcium for her bones.
Okay, great.
So, but thank you. That's gives us other things to think about. Okay, thank you very much.
Of course, you're welcome.
Dolores?
I was just wondering, does when you start your period, does it have anything to do with when you're going to have menopause?
I don't know. I'm not sure if we know that. We do see that women in families tend to have menopause around the same time. But I don't know if we know that there's a link. Like we can say if you start early, you're going to finish early. If you start early, you're going to finish later. I'm not sure. I'm not sure if we know that yet.
Okay. Thank you.
Darryl, you had another question?
Yeah. Do you recommend estrogen therapy for women that have moderate to severe menopause symptoms?
I do. I think that if you are going through menopause, most of the times the symptoms occur before menopause, meaning the end of periods before that has occurred, and early in the process. So if I think that's the most effective treatment to help with those symptoms. Um, but it's important that it started when in the early stages of when you're having symptoms, and also you start at a low dose and then adjust the dose as needed. For women who've had a history of breast cancer or ovarian cancer, and there are other options besides estrogen to help with the symptoms in particular. Like if it's hot flashes, there are new medications out now that can help specifically with that. If it's vaginal dryness or pain with intercourse, there are like vaginal creams or ointments that women can use locally that will help with those specific symptoms.
I have a question. Is there any advice to women over 50 uh, as to how often they should have sex, or is there any limitation on their sexual drives after the age of 50?
Well, the drive definitely changes. Uh, I mean, way before 50, but it definitely will change after 50. Um, I mean, a woman, I guess the recommendation is a woman should have sex as much as she wants. If she doesn't want to, then, if it's really that she doesn't want to, then but she physically can have sex as much as she wants. If there are problems like pain with intercourse because of the change in the vagina after menopause, then she should talk to her doctor because we do have ways to help with that. But definitely there could be a change in the actual tissue in the vagina. It just is not as supple or stretchable, and there's not as much lubrication. But there are medications we can use, like the estrogen that you can use in the vagina. Also, systemic estrogen, like a pill, you can use that will help. And there are other types of moisturizers that we can use there to help with that. Definitely, interest in frequent sex can wane during those years. If it's a problem within a marriage, then that's something that should be addressed. But yeah, women can, if they want to, keep having sex as long as they want to.
Okay, thank you. I don't see any more questions, so we're very grateful, Dr. Callender, for your answers to all the many questions that we posed to you. And thank you for the excellent presentation. And can't thank you enough for addressing many of the issues. And I guess we will always remember that after menopause, there's no reason for you to think you don't need to get a vaginal examination. So we'll take that lesson and share it.
Thank you. Thanks for the opportunity. I'm happy to be here.
Okay. Okay. let's see, next week is the 25th. Yeah. Okay. All right. So, God willing, see you all next week.
Be safe, all.
Yes, thank you so much.
You're
Bye-bye.
welcome. Bye.
Bye bye.